My name is Kirsten Busey, and I work for the Child Protection Team. I'm actually the program manager for Santa Rosa and Escambia County. I've been with the Child Protection Team for about 9 years. Today, what I'd like to do is kind of go over the impact of abuse and neglect on our community, and also talk a little bit about the investigative process and CPT's role in that. So as far as the impact of abuse on our county, actually on the nation, there was a big study done back in the 80s and 90s where 17,000 people were surveyed as part of their normal health care. This was done through Kaiser Permanente, a very reputable medical facility out west. And basically what they did is interviewed these patients in 4 different domains. About 3 types of abuse, 2 types of neglect, and then 5 types of family dysfunction, which could be anything from exposure to domestic violence, drug use in the home, mental illness, divorced parents, any kind of trauma that they might have sustained as a child. And what they found when they linked all this information together, you'll see I've got a slide here, let me go back there. The outcome of this study basically showed them this dramatic link between the number of adverse childhood experiences, it's called the ACEs study, that anybody would experience in their childhood and their likelihood to develop health problems or risky behaviors as an adult. If you experienced 4 or more adverse childhood experiences, premature death by up to 20 years was even cited. Child abuse and neglect really needs to be viewed as everybody's problem and something we all need to try and play a role in preventing and intervening as soon as we're aware of it happening to minimize the number of adverse childhood experiences anybody would have to go through. That being said, some of the reporting laws have recently changed as far as who's responsible for reporting their concerns of abuse or neglect. It used to be that there was this class called the mandated reporters. Well, that's actually no longer the case. Effective October 1st of 2012, the state of Florida decided that everybody was a mandated reporter, regardless of your profession. So what the law says is that if you have suspicions of abuse or neglect and you fail to report those to authorities, that you can actually be held liable with a felony charge and up to $1 million fee. Part of what prompted this change in the law was the Penn State case that there was lots of perceived cover-ups about people being aware of abuse and not taking appropriate action. So the only thing that stays the same as far as the mandated class is if you work in a certain profession and you make a report to the hotline, you are not allowed to report anonymously. So like say a pediatrician had concerns, you can't call in as an anonymous reporter, you need to provide your name and number as a profession. So that's the only difference. I always like to share, just because we all do have that responsibility, the way to report child abuse in the state of Florida is handled through a centralized hotline by calling 1-800-96-ABUSE. So after this report is made, this is kind of what starts the whole investigative process. When that call is made in Tallahassee, and they're open 24 hours a day, 7 days a week, they accept that call and then they assign it to a local county, wherever the child is located. So say a child lives in Central Florida and they're up here visiting their grandparents and they're in Escambia County. That report will be assigned to an Escambia County investigator. It'll be coded as either a 24-hour or an immediate, and that basically says that the child protective investigator that works for the Department of Children and Families has that much time to respond, and the hotline will make that call depending on how severe the allegations are. So the Department of Children and Families manages all of those abuse reports that come in through the whole state. And I can tell you, just for Escambia and Santa Rosa County, there were over 7,000 reports last year annually for reports of suspected abuse or neglect to the hotline. So we have pretty widespread abuse here in these 2 counties. Now, when that report goes into the hotline, law enforcement may or may not be involved at that moment. So it gets a little complicated because ultimately you may have up to 3 agencies working hand in hand to look into these allegations of abuse or neglect, and we all play specific roles, but we have a collaborative approach to our response. So that's the Department of Children and Families plays their role, law enforcement may play their role, and then you have the child protection team. Okay, so I think it's very common to confuse the child protection team with the Department of Children and Families, because we are all under the Child Protective Service umbrella, but we do play very different roles when it comes to investigating child abuse and neglect. So some of the differences I want to point out to you is the Department of Children and Families, they go out in the field, like they'll go to the child's school or they'll go in the home or wherever they need to go to see that child. They respond to every case that goes into the hotline. They have an obligation to go out and check it out. There's 9 units between the 2 counties made up of 54 investigators. So they're a large organization, which they have to be for the volume of cases they're tasked with investigating. And then the child protection team, we do not go out in the field. We are not the first person to commence a case. That would be a child protective investigator with DCF. So they go out, they see what's really going on, and then all the services that the child protection team provides are based out of the child advocacy centers. So that would be the Gulf Coast Kids House here in Pensacola, and the Santa Rosa Kids House is located in Milton. We are only made up of 10 people total for 2 counties. So I have 6 case coordinators, myself and the program manager, 1 administrator, and 2 victim advocates. So we're very small. We don't get involved in every single report that goes into the hotline. We get about 1,200 cases a year as compared to their 6,000 or 7,000. We have no authority to remove children. So I'll just give you an idea. And the history of the child protection team, the reason that we came to be was back in the 70s, I believe it was 1971, the mandated reporting law went into effect. And so that all of a sudden, it was like dramatic increase for the number of reports going into the hotline. So much so that they couldn't quite manage the volume of cases, and there were still cases and children falling through the cracks. In 1978, they launched this pilot project where they decided certain cases rose to a different level of risk and required this safety net or a separate agency to be involved and put their eyes on that child. And this whole effort was to minimize the number of child deaths. It was a medical focused project back in 1978. And then by 1999, it was no longer up to the Department of Children and Families which cases they wanted to involve the child protection team in, because we're under the Department of Health, so we're totally separate. What they did is they wrote into Chapter 39, which governs the laws that allow DCF to investigate. They set out this mandatory referral criteria, is what we call it. So if certain cases met this criteria of rising to this higher level of risk, according to the statute, DCF had to consult with the child protection team and involve us in those cases. So that's where our relationship still is today since 1999. So the child protection team today, there are 25 established teams across the state. We are still medically directed. Each team has a pediatrician as their medical director, who kind of co-leads the team along with the program manager. Our primary funding is from the Department of Health. We also get county funds. We get funding through the Federal Victims of Crime Act, VOCA funding, as well as some grants. And most CPTs across the state are based out of CACs, but they don't have to be. CPT services, as far as what we provide, the ones that people are most knowledgeable about are medical exams and forensic interviews. We did about 552 medical exams in 2012 and about 201 forensic interviews in 2012. We also provide medical record reviews, which is one of our pediatricians or nurse practitioners. When there's an allegation of medical neglect, they'll look at that child's whole medical history to figure out whether or not neglect has or has not occurred. So that's a common service we provide. We did 32 of those last year. We have a different kind of interview than the forensic, which is called a specialized interview, and we do those mostly with caregivers or anybody that would bring a child in for their assessment. And although we do focus on the allegation because we want to know what happened and what brought the child to DCF's attention, we also do a lot of broad risk assessment. We ask a lot of in-depth questions about risk, anything going on in the home, risk factors to how they got where they are, including their own upbringing and some issues that they might be having personally. So those are called specialized interviews, and we did 553 of those last year. We have staffings, which is an invaluable service to the multiple partners that we work with on these cases. There's no simple case. They all are pretty complex, but when we have one that's particularly complex or the disciplines involved are not in agreement, CPT will facilitate a staffing where we just get everybody to the table that was involved in the case, and it's a great way to share information and safety plan for the child. We did about 30 of those last year. Every child death that gets reported to the abuse hotline is also referred to the child protection team, and we do a staffing in almost every child death, as well as usually reviewing the child's medical history and the autopsy report so that we can render an opinion about abuse in those cases. Unfortunately, we had 27 of those last year. We also have a psychologist on our team. He's actually contracted. Mental injury is one of the hardest types of abuse and neglect to prove, and he helps us do assessments on children so that we can try and help DCF make an opinion about that. And then obviously everything that we do, we have to be willing to provide court testimony on. So we go to court quite often in both dependency and criminal proceedings. So I mentioned before that in 1999, the statute changed and mandated DCF to involve the child protection team in certain cases. Without getting into too much detail, a good way to think of it is any case where there's evidence to be gathered. So if you have a child that it might be alleged that he's being physically abused and he was spanked last month, if that child doesn't have an injury, then they're not necessarily required to refer that child to us for services. But if an abuse report gets called in and they go out to the home and the child actually has a physical injury, then we are tasked with documenting that and diagnosing whether or not that injury is because of abuse or is caused by an accident. So that's another reason it's really important as reporters that we don't delay in reporting so that we can get reports called in when a child actually has physical injuries to be documented, because it really strengthens the case and gives us a better idea of what risk that child is at. So those are kind of the physical abuse cases that rise to the level of being referred to us. It's generally known that children 5 and under are at higher risk because they're not visible in the community. They oftentimes don't have the verbal skills to tell people what's going on in their world. So a child 5 and under that has a bruise anywhere on their body should be referred to the child protection team for services. If they're older than 5, the areas of concern we look at are the neck, face, and head, because those areas are more vulnerable for serious injury, and they also suggest that a caregiver is kind of out of control at that point when they're trying to discipline. Any report of sexual abuse should be referred to the child protection team. Reports of malnutrition and failure to thrive, as well as medical neglect, and then serious emotional problems or concern for mental injury where the child is actually demonstrating behaviors like cutting or real socially withdrawn, depressed type symptoms. We can have our psychologists look at those cases. And then any time that a child death is called into the hotline and there's surviving siblings in the home, those cases should be referred so we can look at those surviving children. So that's to give you an overview of when we get involved and what we do when we get involved. And I'd like to kind of go through the different types of abuse that we would be involved in, starting with physical abuse. I'm going to go over some neglect cases and then also some things about sexual abuse. So I'm going to be referring to some pictures through this section on physical abuse. Most of them are actual children that we've seen. A few are textbook pictures, so I'll try and remember to let you know which ones are which. So when you talk about physical abuse, the whole thing is trying to match up the history with the injury. I mean, that's really what the child protection team and our examiners are tasked with. Sometimes the strangest, most horrible looking injury can have a very good explanation. So that's really what we're listening very close for. So if you're ever in a situation where you're gathering information or thinking of making a report, the initial information that's given to you either by the child or their family, it's really important that that's documented clearly, because what we look for is those things to change over time. Usually if it's a true story, there aren't many variations in the history being given, versus if somebody's covering for an abusive situation, that history will change. I already mentioned injuries to the face, neck, head are more concerning. Also the abdomen. When you think about how a bruise happens, it's when tissue gets smashed against a bone and that the little capillaries break. So if you've got injuries over an area that you don't have any of those harder surfaces like the abdomen, that means pretty significant force was used, and also might be internal damage that you wouldn't be aware of on the surface. A good thing, a good acronym to remember is children 4 and under are unlikely to have bruises to their torso, ears, and neck that have been caused by accidental means. So that's 10, T-E-N, torso, ears, and neck. Those are highly suspicious for being inflicted unless there's a really good explanation or a witness or something like that. So we look at those very carefully. And also when you see a child who has lots of bruises in multiple stages of healing, just kind of raises your concern. So this first picture is pretty typical of injuries inflicted by a flexible object, often a belt or a cord or something like that. And they've got that obvious loop-shaped pattern to them. And oftentimes we do see them on the back or the butt. One thing we pay attention to is how many different planes or surfaces the child's been struck on. It gives you an idea of how much time a caregiver might have spent on this event. Obviously, the more loop marks we see, the more concerned we are, and if there's broken skin, it gives you an idea of the force used. Okay, this next one is an unusual bruise pattern. I say unusual, but we actually do see it quite frequently, where you see the actual, what we call the gluteal cleft, or right there between the butt cheeks, is spared. And so you think, well, what kind of object would have caused this pattern of bruising? And what it is, it could even just be a hand or a flat surface where the child would clench their butt cheeks together in anticipation of being struck, and the surface that it hits is actually the top of the butt cheeks, and the center is spared. So that's another common pattern that we look at. This is a little 2-year-old child, and I don't know if you can appreciate this on this slide, but he's got some linear bruises across his cheek there, with some sparing in between. And that is a pretty typical slap mark. And oddly enough, where you see the bruises is actually not where the finger struck, but where the blood was pooled and forced up in between the fingers. The blood kind of gets out of the way when the fingers hit it, and the bruising is actually what you see between where the fingers are. Now, we don't have the skills or the tools to match that up and say that's a male hand or a female hand, or that's this person's hand, but we can say for sure this child was hit with some pretty good force to cause this pattern. Whenever we see this, we look real good inside the cheek, make sure there's no injury inside that the teeth would have caused. Sometimes they'll have some hemorrhaging to the sclera in the eye if they're hit hard enough, like the little white part in their eye. I can't show you this young man's eye, obviously, for confidentiality. And then also it can sometimes wrap around and you'll see bruising behind the ear. So we look real close at this little guy because of course he can't tell us what happened, but the history was that mom's boyfriend was upset with him. He spit his peas out at dinner and he got upset and slapped him. That man actually happened to be active duty military, and so we work close with military bases where and law enforcement in that way, where this man would have kind of been put on lockdown at the base until we could sort all this out and make sure that this child could stay safe. Okay, this next one, you can see what we call petechiae, or it's little pinprick reddish bruising up around this child's neck under his chin. And the odd thing was this child went to the emergency room with a rash on his abdomen. And so initially the doctor thought that this was more of that, was just kind of a continued rash up his neck. And fortunately, a nurse saw this and saw that it was what we call bilateral, which is injuries on the same, that look the same on two sides of the body. And she was a little bit concerned that maybe it wasn't just the rash and that maybe he was injured. So she did the right thing. She called in an abuse report. Investigator goes out, sees this little baby. He's got these marks, so they call the child protection team. We bring him into our exam room. And in fact, these are strangulation marks. He had the hemorrhaging, like I mentioned before. He actually had little petechia under his eyes, which would suggest lack of oxygen for some time. So again, this is a little boy who's not safe where he is. And if that nurse would not have called in that report, children who present to ERs and there's a failure to report are at very great risk for escalating injuries to include broken bones or shaken babies. So this situation was good that we could get services involved and get this child safe with these injuries versus something more severe. This next one, you'll see this measurement tool, and we actually use that a lot. This one that's shaped like an L we use in particular to measure bite marks. We get referred a lot of bite marks, and we realize sometimes kids bite kids. That happens even in the best of scenarios. You can't always be watching everything. But what we get really concerned about is an adult biting a child. So we have a way that we can measure cuspid to cuspid and know whether it's the size of an adult mouth or a child mouth, because the risk factors to the child are dramatically different. Adults biting children, I think back in the day, was advised as a way to curb biting behaviors. We would never recommend that, but we do consider that when we're looking at these cases and look at, is this child of a biting age? Is this a frustrated caregiver with a biting behavior? So a bite mark inflicted by an adult in that way has even been described as a pre-homicidal type behavior and very dangerous for a child. When we have a child that's 2 or younger or not verbal for some reason, and we have a positive finding for physical abuse, which is what we would, our choices when we see a child for physical abuse are positive, negative, or indeterminate. So if we have a positive finding in a nonverbal child, we will send that child for a full body x-ray, or what we call an infant trauma survey, to make sure that there's not other injuries going on that they just can't tell us about. And oddly enough, sometimes we do find healed fractures, which again gives us an idea of how long this child has been abused or the severity of the abuse they're enduring. Okay, got one more here. This is an older child. This is a school ager who's visible in school and went to her classroom. She's 9, I believe. The teacher saw these linear marks down her arm. So she sent her to the nurse. The nurse went ahead and called in an abuse report. They went out, looked at her, sent her to the child protection team. We did a forensic interview with this child initially before her exam, which I'm going to explain a little bit later, but recorded interview. And when we were in the interview, she kept shifting in her seat and was having a hard time sitting. And then we went across the hall to do her exam, and I'm going to show you pictures of her bottom and leg that are pretty graphic, just to warn you. This is actually the abuse, the injuries that she had. These were inflicted by a speaker wire by her father. He had just gotten out of prison for drug charges. They were living with his mother. So this child was living in the care of her paternal grandmother. Dad gets out of prison. He comes to stay with them. Well, unfortunately, the paternal grandmother kept this child home for school for 2 days and didn't report this incident to the authorities. So she could not be viewed as a protective caregiver by DCF, and this child had to be removed and put in foster care. Okay. Another thing I want to point out when we're talking about physical abuse is the child protection team does consider injuries that are inflicted during the course of a domestic violence incident to be physical abuse, and oftentimes we'll add maltreatments and failure to protect in addition to that. Domestic violence, as you all know, is escalating in our community and really accompanies lots of other serious maltreatments. Usually, we have underlying domestic violence in all cases of substance misuse, physical abuse, and sexual abuse. It's also a common factor in child death cases. Law enforcement is really being pushed right now to, if they get called out to a domestic disturbance, if there are children in the home, it doesn't matter if they're asleep or witness the abuse, they're obligated to call in a report to the abuse hotline. So we're seeing a lot more domestic violence cases come our way. I am going to spend a few minutes talking about normal bruises, because fortunately we do see kids with normal bruises, and often, not often enough, sometimes we're able to render a negative finding. Some common normal bruises would include like facial scratches from a newborn that has those long sharp nails. Shin and knee bruises are very common. Forehead bruises. Any bruises over bony prominences can be conditions that are not abuse. This first picture I'm going to show you looks horrifying, because this child looks like she has 2 black eyes, and in reality this is a textbook picture. This is the way that a rare cancer presents. So this child had an oncology issue and was not an abuse victim. This picture shows the back of this little girl, both of her legs, and so the reporter was right in calling this in, because like I said, anytime you see the same injury on both sides of the body, we call that bilateral injury. It's very uncommon to be accidental. So it looks like maybe somebody tied this child up or bound her in some way, but in reality, when the grandmother brought her with her sandals in for the appointment, they were new sandals, and she had gotten these rubbed raw areas from walking in them. Another common thing that the child protection teams ask to evaluate are Mongolian spots. They're kind of like birthmarks. They're most common in biracial children or Asian descent. They can be found in any ethnicity, and they're most common on the bottom and the lower back, but they can be up on the back, arms, legs, anywhere. So they look remarkably like bruises. They're bluish, purple, they can be even greenish, and so we'll look at those and try and figure out if they're bruises or Mongolian spots. Sometimes even our examiners who are trained have a hard time discerning the difference, and so we'll bring these children back a week or 2 later to make sure that it's exactly the same and make sure they're not bruises. Okay, we're going to get into burns a little bit. Different types of burns that we see is cigarette burns. We also see like branding burns, or where a hot object is held to a child and it takes on that exact pattern. Or scalds from immersion burns, where somebody would put a child in a hot tub or a hot sink or hold their hand under hot water. Burns are tricky because they, everybody's skin heals and responds differently, and so sometimes patterns are hard to appreciate. And if that's the case, we have experts around the state and actually around the nation that we could send our burn photos to try and help us get an idea of whether it was an accident or inflicted. Because obviously if a child is being burned by their caregiver, they should not be in the care of that person. So we really want to make sure we get that right. I'm going to show you some examples here. The bottom of this little one's foot. This is a 9-month-old. The story was that mom was playing a video game, had ashed her cigarette on the carpet, and she said this child stepped on her ash on the carpet. But if you look, it's completely circumferential, and the center is compressed, like it's a deeper sore than that around it. And so this would have been a cigarette actually put to this child's foot. And what mom should have realized is that this child doesn't even walk yet. And so her telling us that this child walked on her cigarette ash, she couldn't walk unassisted yet. She's only 9 months old. And we tried to get her to walk just to make sure she was not walking. So this child was removed, and mom had some substance abuse issues as well. This is an unusual pattern. We actually went and bought a cigarette lighter, or a Bic lighter, because it really looked like it was a lighter burn pattern. And in fact, when you hold the lighter up to it, it's exactly what it was. So this child had a lighter held to their arm, and the story was that they were grilling and the child had tried to go over by the grill, and so the caregiver picked the child up and somehow burnt the child's arm with the lighter. But when you held the flame out with the lighter, even if you immediately put your finger on it, it wasn't hot enough to burn. So this would have taken more time than what the caregiver said to cause this kind of an injury. Next one is an immersion burn, and so this is the feet of a 2-year-old seen at the emergency room. And the bottoms of this child's feet are spared, and what I mean by that, there's no blisters, the skin's totally intact. And so sometimes we'll see that where if a child is put into hot water, if their feet make contact with the tub does not warm up as fast as the water around it. And so sometimes if you have any part of their body compressed against the bottom of the sink or the tub, that actually won't burn because it's not as hot as the water. Also, the bottom of your feet have more layers of skin than the other parts of your feet, so they don't burn and blister as quickly. Believe it or not, and I don't mean to say anything negative about our ERs, but they were about to send this child home from the ER with some burn care instructions. The child protection team went out, we undressed the child completely, which is our practice, and the child actually had some splash burns to her genital area, which fortunately, well, that part's not fortunate, but fortunately, that qualified her to be transferred to a burn center, and she actually ended up needing some skin grafts. In addition to these burns, she had some loop marks on her abdomen that the ER staff did not see, and we took a look at her siblings who also had inflicted injuries. This is a textbook picture, but we have seen similar ones like this here at the Child Protection Team in Pensacola. This pattern is actually the bottom of an iron, and you'll see the triangular tip up by the inside of the elbow, as well as the steam holes. So somebody held this to the child for some time to be able to see those exact steam holes. We always look at where the burn is, because children will explore most with their hands, and so if they're touching a hot object, it'll be with like the palm or surface of their hand. So children, if they've got burns to their back or the inside of their arm, it's an unusual place for them to bump into things accidentally. So we'll look at that too. This circular burn is actually an old car lighter is what was used to inflict this burn. We saw 2- and 3-year-old children who actually both had some of these on their legs. And Mom's story was that the 3-year-old got the car lighter out of her car and was stamping him and his sibling with the lighter and burning them. Except that the 3-year-old had multiple burns, and so cognitively and just developmentally, a child would not inflict. If he did it by accident one time, probably wouldn't be perfectly circular, and he wouldn't have done it again and wouldn't have done it to his sister after that. So these were inflicted burns, was our opinion on that. That was a positive finding. Okay, moving out of burns into fractures. Children can fall, break their bones, but fractures of any bone in a child who does not yet walk is suspicious. There are certain fractures that are more concerning than others, and I don't need to get into all those details, but basically children are not made to break easily. They've got a lot of collagen in their skin, which is almost like a bubble wrap for them. So it takes more force to cause a broken bone in a child than it even would an adult. And so when you think of an adult, say they roll off the couch and fall off the couch, they don't all of a sudden have broken ribs and broken legs from doing that. And so sometimes we'll have a baby with a couple of fractures, and the story is that they rolled off the couch, which we need, doesn't always add up. So if a child has one fracture, we will do that trauma survey again to see if they have any other fractures. Obviously, the more fractures, the less likely it is that it's accidental. The most common inflicted fractures are to the ribs. It's a very protected area, and oftentimes it's like car wreck type forces that you would need to cause a rib fracture. So our doctors are trained and have done a lot of research about which types of fractures are suspicious for abuse and which aren't. It used to be thought that spiral fractures were automatically abusive, but what they've realized is your bone can actually fracture in that way if you've got an active toddler and they plant their foot and twist and things like that. So we take a lot of time to make sure we get those cases right as well. Another type of pretty severe physical abuse was commonly referred to as shaken baby syndrome, and now more people refer to it as abusive head trauma. That's probably the worst sequela of injuries, of cases that I've seen since I've started here. Kind of the trio of injuries that are common are retinal hemorrhages, usually in both eyes, and then the brain bleeds, and oftentimes rib fractures. So if a child is grabbed around their ribs and shaken back and forth, a lot of times you'll see what we call posterior rib fractures, which is near their spine area, because that's where the majority of the pressure is from the squeezing. And then when you think of like brain bleed, it's kind of, their head is so big compared to the rest of their body, so their head moves back and forth, and the brain inside doesn't move at the same rate. So the skull, there's kind of a shearing effect between the skull and the brain, which causes some tearing of those blood vessels and the bleeds. And so the effects of that can be very widespread. Some babies can have a small brain bleed and there's no obvious sign, and it heals and life goes on. Some, depending on what area of the brain is affected, will lose their ability to swallow, to breathe. They'll start having seizures. They'll decline very quickly. Oftentimes, by the time they are declining that quick and go to the emergency room, we suspect that that is not the first shaking incident, that possibly the first shaking incident just didn't result in that level of injury. And usually it is crying that prompts a caregiver to get that frustrated. That's really all an infant can do, is cry. And we've seen a large connection between video games and a crying infant and the care of mom's boyfriend. That seems to be a very common scenario where a baby is shaken. Okay, that's all I've got on physical abuse. I'm going to get into neglect a little bit. Neglect is a really broad category. You can have neglect in the way of just inadequate supervision, where you'll have a child sneak out of a home or walk out of a home, fall in a pool. That is a preventable scenario. Or you can have failure to thrive, where a child's nutritional and emotional needs are just completely not being met, and they'll lose weight and they'll have a really flat affect and be developmentally delayed. Then there's medical neglect, where say you have a medically complex child and their caregiver's failing to bring them for their appointments or give them the medication they need, things like that. And then there's dental neglect. So we do get involved in all of those scenarios. The ones that really DCF relies on us to help them with are the failure to thrive babies. And I do want to point out, the physical abuse pictures are most impressive, but children are far more likely to die of reasons surrounding neglect than they are abuse. I'm going to show you a couple pictures of some failure to thrive babies. I don't remember the age of this little one, but what we do when we go out to the a lot of times these kids fly under the radar until they go to get their WIC coupons or get some services, and they'll do a weight check and realize the baby's fallen off the weight curve, the growth curve, so they'll admit the baby to the hospital. Unfortunately, if that takes place prior to 6 months in their life, they won't ever actually catch up at that point, regardless of what services are put in place. Physical therapy, occupational therapy, you can do every service under the sun, and they will never reach their full potential because of that neglect, because their brain has missed out on that opportunity. But when we go to the hospital to see these babies, we take full body pictures. It's real important to see the lack of fat on their bottoms. They oftentimes will have that big protruding belly. These little guys, the next picture, these are twin boys actually, and they were 9 months old, maybe almost 10 months old. Both got admitted to the hospital, were not yet able to sit unassisted, so they were severely developmentally delayed. If you look on the bottom right, you can see how flattened their heads were. That's a real common thing to see in neglected failure to thrive babies as well, because they're left laying on their backs a lot. They have real weak cries. They're used to crying and not having their needs met, so they oftentimes don't put up a lot of fuss by the time they're neglected to that level. I've got another picture. This is a different type of neglect. This is inadequate supervision, actually. What you see on the back of this little guy are multiple child-inflicted bite marks. This child was in foster care, and another child in the home was just biting this kid up. And so at that point, with that type of injury, you got to wonder, where was the caregiver? How did the caregiver not try and intervene after the first bite? So this wasn't a good situation for this little boy to be in. This is kind of a gruesome picture, but this is the end of a 16-month-old's little toe got chopped off. And so it was a pretty significant injury to lose the tip of your toe. And when we started talking to the mother and her boyfriend, nobody could say what happened to this little girl. The story was that she got put down for a nap, woke up missing part of her toe. So they go and look, and there's nothing sharp in her room. There's nothing, they really never figured out what happened to her toe. So at that point, you know, unfortunately, it's hard for the child protection team to make an opinion. Did it happen accidentally while somebody wasn't watching this child? Call it inadequate supervision, or did somebody cut her toe off? It's an unusual way to physically abuse somebody as well. So in those cases, sometimes we're left with an indeterminate finding for physical abuse, but definitely a positive finding for inadequate supervision. Okay, we're going to just briefly talk about the role of the death review team, and then I'm going to get into sexual abuse, and we'll wrap it up from there. Okay, so if you're ever invited to a staffing, a death review staffing, say you've been involved with a family and a child in the home dies, participation at those is really critical, because things that you've observed and heard in that family may not seem relevant, but when you put all the pieces together, sometimes it can become very relevant. Because of the child death review team, EMS, our first responders here in this county, has actually rewritten their protocols so that when they respond to a child death, they're treating it more like they would an adult homicide. Before, they were always very mindful of being cautious of the family's feelings, and they would never want to pronounce the child's death at the home. They would want to kind of scoop the baby up and certainly give the impression they were doing everything they could to revive the child, and usually pronounce the child's death at the hospital. And while that's good and sensitive to the family, they were finding that very few child deaths are true accidents. And so they felt like they needed to keep the integrity of a potential crime scene more intact and do a lot of the investigation right there on the site, because babies really aren't made to die easily. They're little fighters, and they're made to live. And so when you have a child die, you should be alarmed just like you would if an adult died in their home. So that is really good progress that we've made here in these counties. We've also started looking at unsafe sleeping environments, where those used to be called SIDS deaths. We're now realizing that very few children truly just die in their sleep of no known cause. A lot of times they're in a crib, or where there's lots of bedding or things that obstructs their airway, or they're sleeping with an adult. So the pediatricians and hospital staffs have done a great job partnering with us to try and get the message out there that that's not safe for babies. So that's what I have about child death. We're going to get into sexual abuse. And just some facts I want to point out on some misconceptions maybe about sexual abuse. Majority of children that are sexually abused, it is by somebody they know. Only 5 to 15% of sexual abuse victims are victimized by strangers. So the whole stranger danger mentality and concept is really outdated. If you think about it, somebody who has access to a child is going to have much more success in perpetrating sexual abuse on them than grabbing an unknown child off the street and doing that. So sometimes perpetrators will put themselves in a position to develop that relationship with the child and their parents, and gain the trust of their parents and their, kind of built-in trust with the child. So that's how that happens. Majority of our cases do not involve physical findings. In fact, less than 5%, and I think 5% is generous. Very, very, very few cases do we have physical findings. And what I mean by that is when we go to do an exam, that there's actually evidence of trauma or penetration that we can capture in an exam. The reason for that, the reason we have less evidence for child victim cases than we do adult, is children will oftentimes delay in disclosing. So they might have abuse having gone on for some time, or maybe it was only one incident, but they don't normally tell right away. And there's lots of reasons for that. But that delay in disclosing, we lose our ability to try and capture physical evidence. The body is made to heal very quickly, especially that tissue in the genital area. I like to compare it to the tissue in your mouth, which probably sounds strange, but it heals very quickly. If you get a cut inside your mouth, it'll heal more quickly than if you get a cut on your arm. So that's another reason that we often don't see physical evidence. So that being said, the history given by a child becomes the evidence, and that's why it's very important that we document that correctly and that we get the details right, because a lot of these cases come down to the child's word against the perpetrator's word. And perpetrators oftentimes will pick children who do not make good witnesses. They have behavior problems, they might be developmentally delayed, special needs children, who are not real believable children to adults to begin with. So that's something that we get special training in how to interview children with those types of disabilities or delays. Another thing I want to point out is that victim disclosure is a process and not an event. I think it's common to think that a child will make a conscious decision to disclose their abuse on Monday, and they'll wake up Monday and go, today I'm going to disclose sexual abuse, everything that's happened to me, and I'm going to start at the beginning and I'm going to tell every detail until the end, and I'm not going to leave anything out. And that is not how it happens. A lot of these kids will disclose by accident to a friend or through their behaviors, and then they judge the reaction of those around them as to how safe it is to give more information. So it's very common for kids to disclose in increments and give little bits of information over time. Some of that is a coping mechanism, but a lot of that is they're trying to figure out, should I be saying this or shouldn't I? So, sometimes you'll hear juries say, well, they changed their story, or they're not consistent in what they're saying. Well, it's less likely that they would be able to maintain that consistency and tell everybody the same thing every time. A study showed that more than 50% of victims do not disclose abuse at the time of their abuse, and only do so for research purposes. So that just goes to show the victims that we do identify, the ones that do disclose, is just a fraction of the actual abuse that's probably going on in our community. So when a child discloses, they need to be heard and they need to be listened to, and that's part of the role that the child protection team fills as well. 4 to 22%, I don't like to use a lot of stats, but I think this one's important, between 4 and 22% of children recant true allegations at some point. So that means that a child will disclose and all of a sudden their world comes crashing down around them. Mom's boyfriend goes to jail, or the sole support, I don't want to say mom's boyfriend, maybe their father goes to jail and he's the one that supports their household, and now mom's freaking out and upset, and how are we going to pay our bills, and why did you say that, and maybe you've got a sibling in there saying it's all your fault that daddy's in jail. All those pressures come in and they go, you know what, my life was a lot better when I was just being sexually abused, because this is too much. And they'll say, I didn't mean that, I made that up. And we call that false recantation. And some kids will go through phases of that during the investigation, and it makes it really complicated and difficult for a prosecution in a criminal case. But that is the reality. Between 4 and 22% of kids will do that. I already talked a little bit about perpetrators, but I want to talk a few more minutes about that. They are close to the child normally. They used to think that perpetrators of sexual abuse likely experienced sexual abuse as a child, like they were a victim themselves. And although you do see that phenomenon, the more common thread is witnessing domestic violence. And I'd heard that repeatedly at seminars and trainings I've gone to, and I never could quite understand that connection. So I went to our counseling program, who does the services for the children, and I asked them why that link was between the exposure to DV and perpetrating sexual abuse. And they said that if a child grows up in a home where they witness domestic violence repeatedly, it's a very you have no control over that situation. It's a helpless feeling. They want to help, protect their mother or whoever, but they don't have the ability to. So as they get older, they're always trying to seek out that way to control their environment, because they weren't able to do that as a child, and the ultimate power and control is to perpetrate sexual abuse. So that's how it was explained to me. Oftentimes a perpetrator does not want to harm the child. They will spend a lot of time grooming that child, breaking down those sexual barriers. They might show the child pornography, kind of get them comfortable with a certain level of sexual discussion, things like that. And most often it fosters secrecy, whether through threats or presence or guilt, whatever, they'll try and get the child to be quiet about it. Some disclosure obstacles, obviously the child's fear of their perpetrator, their fear of the other people's reaction to what they have to say. They might feel responsible for it, and we see that most often in male victims, that they feel like they were actively participating in whatever abuse did occur. Some of them just don't know what's wrong. It's gone on so long, they don't even realize until they're at a slumber party when they're 12 and talking with other girls that other girls aren't going through that. And they oftentimes don't want to upend their family. So when does the child protection team get involved when there's allegations of sexual abuse? Basically, we need a verbal child to be disclosing, to be giving history. And so unfortunately, we can't always just go on like a parent says, well, my child told me this. We need to know that that child is comfortable enough emotionally and that they're in active disclosure where they're going to tell a professional. Because then we know that they will endure the forensic interview process better than if they're only disclosing to their mother or their aunt or their grandmother. So that's one thing we look for, is are they giving history to during discovery interview by law enforcement or DCF. And then also any child who's been diagnosed with an STD, even if they're not giving history, we'll take a look at that and try and determine what's going on, if they contracted the disease by non-sexual means or if they're at risk for sexual abuse. And obviously, if a nonverbal child has visible signs of trauma, we would get involved in that. So there's a couple different ways that we respond to those. Immediate, obviously, and then sometimes we can do a non-emergent response. So things that are important for us to know to determine how we're going to respond is if the alleged abuse happened within the last 72 hours. That's kind of our window for capturing evidence. Sometimes real young children aren't able to give us those time frames, so we'll just look at last contact. We don't know if that's when abuse occurred, but we'll err on the side of last contact. Obviously, acute trauma, we would respond immediately, or if there's safety issues where the alleged perpetrator can't be put out of the home, say it's dad and this child is going to go back home to that home, we would go out immediately on those cases as well. Non-emergent is if it's last month that this happened to a child, or when they were in California visiting their uncle last summer, things like that. Those we prefer to not go out in the middle of the night of. First of all, the interviewer is not at their best. Oftentimes we end up with a tired child who's not really interested in being interviewed, things like that. So we look at the whole picture and decide what's the best response. A lot of times people will call the police or bring their child to the emergency room when they disclose sexual abuse. And so law enforcement knows how to reach us, the ERs know how to reach us, so we'll staff through all that information and figure out if we need to go out that night or schedule the child for another day. If we decide we're going to respond emergently, we usually reroute everybody over to the CACs. That's a more conducive environment for a child than an ER, and we'll do the sexual abuse exam at the CACs. So at any given time you have a child protection team case coordinator, they're the ones trained to do the interviews, and an examiner on call, and they'll respond together. So as far as the sexual assault exams, there's this misperception in the community, and I think very widespread, that it's a traumatic experience. And it really is not. In fact, if we do an exam on a child who hasn't gone through puberty yet, we don't do anything invasive. They don't use a speculum. There's nothing internal about that exam. We have highly magnified equipment at the CACs that can take photo documentation internally of the hymen and all the other parts to make sure that there's no trauma. So that's a really important thing for families to understand, that we don't have to sedate children, we don't have to hold them down, it's not painful, and so we're able to do all that without causing more trauma to the child, which is our whole goal. If we do decide that an assault kit needs to be taken, all the case coordinators have those with them, and we follow the chain of custody with law enforcement and have all of that taken. If it's not within 72 hours, but we still need to do an exam and check for physical findings, we'll obviously have the photo documentation of any scarring or injuries at that point. Okay, I've talked about the forensic interviews. All the case coordinators go through intensive training to be able to conduct those interviews. The model that we follow is called APSAC. Basically, it's a very loose model that it's child-directed, but interviewers are trained to ask children questions in manners that are not leading or suggestive. It basically gives the child an opportunity to provide narrative responses to describe the abuse that happened to them. Those are all recorded. At both CACs, we have certain rooms that are designed for that. The only people in the room are the child and the trained interviewer. And then there's a camera mounted on the wall. I put a picture on a slide here so you could see what that looks like. And then there's a two-way mirror kind of covered by an art screen, and law enforcement and DCF witnesses that interview from a separate room where we take the DVD recording. Before the interview is ended, the interviewer will get up and excuse themselves to go make sure that law enforcement or DCF doesn't need clarification on anything, things like that. The reason we do that is we really only want a child to have to go through this process one time. And so if law enforcement and DCF can witness, then we can get everybody's questions answered right then without multiple people having to talk to the child over and over. The only tool we really use is a body diagram. We don't use anatomical dolls so much. There's a lot of controversial research out there about the use of those dolls. We have a basic human figure that we'll refer to. Children have all different kinds of names that they use to refer to their body parts, and so sometimes we're not clear on what they're referring to, and we'll have them identify that on a body diagram. We also use the diagrams to do body safety, so if a child comes in and doesn't disclose sexual abuse during a forensic, we still talk to them about ways to keep their body safe in places that are private and not okay for people to touch. Those DVDs are used for court, most often in the criminal proceeding, but it unfortunately does not prevent a child from having to testify, thanks to some Crawford versus Washington case law. The accused has the right to face their accuser, even if that's a 4-year-old child, and so these DVDs do not prevent that process, but what it does is it kind of freezes time. It gives a good picture of what the child has, the abuse the child has had to go through, and a lot of times that lays a really strong foundation for a case where a suspect or alleged perpetrator might plea out and won't even go to court. But if it does go to court, it still saves the child from having to take the stand and give every detail of what happened to them because it's already recorded. And then obviously the case coordinators have to testify to that. So as I already mentioned, we are available. We do 365 days a year, 24 hours a day, 7 days a week, on call. We're reached through the Sacred Heart switchboard, 416-7000, after hours and on the weekends. And then you can always reach us during regular office hours. We have a centralized triage system by calling 595-5801. So we encourage anyone who has any questions or concerns to call us at any time, and we're happy to help. Thank you.